There's a tremendous opportunity to really create these protocol-specific registries. So in other words, if you have 500 or 1,000 patients treated with one set of therapies, the combination of those therapies may have really different risks and different profiles. When the U.S. Food and Drug Administration decides whether a new cancer medicine is safe and should be approved for use, they're only looking at short-term safety data. There is no requirement to say, well, 5 years from now, 10 years from now, is there a price for the cure? And so part of what needs to happen across the board, whether it's pediatric or adult, is for these patients that have had life-saving therapy against cancer, whether it's a child or adult, to really be able to follow carefully, serially, with little missing data to determine what is the course, 2, what are the risk factors, and 3, what markers can you measure that may help predict who's going to do well and who's not. Until we can really have those registries in place, we're not doing the best we can for these survivors. The other thing is as we understand the course and the risk factors and validate those markers as predictors of health or disease, then it behooves us to really do the kind of multi-center studies to say, how can we alter that course? We developed in our preclinical models a drug that could protect their heart from getting that damage without interfering with curing cancer. But right now we have far too many guidelines that have very little data and evidence to support them. And in contrast, we have very, very few intervention studies that are clinical trials to really look at, now that we understand the course and the risk factors and markers that can predict this, what can alter that in a way that gets to better quality of life for these survivors.